it's good to talk about something other than diabetes once in a while, because I always, though I always enjoy talking about diabetes, sometimes I find I'm a little out of touch with diabetes, with things other than diabetes, and therefore it's a good opportunity to talk about testosterone. And I will just talk about some aspects of testosterone therapy with discussing a few cases. So this is going to be my agenda. I look at an introduction, I'll discuss one case, followed by a second case, and then summarize. So I'd just like to introduce by saying that historically it was Brown-Sequard, his observations about his own physical strength and intellectual capacity after injecting an animal extract of liquid testosterone prepared from animal gonads. And he found that his strength and intellectual capacity improved. Today, if you look at the ICMR guidelines for doing research, this doesn't really fit into the ICMR guidelines. But those were the days where things were possible and things were tried, and he tried it on himself. Today it's not even legal to do that, but this is just an introduction. So the incidence of low testosterone in aging persons is very high. It's about 12 per 1,000 person years. And like Dr. Seshadri showed you, not all people need to be treated, and sometimes testosterone gel, when applied to men who have intercourse with women, can lead to excess testosterone in women through absorption through their skin, and that can lead to hirsutism in the lady. And that's what Dr. Krishna Seshadri, the case which he was trying to tell you, was a case where testosterone gel was applied to the male, and there is a risk of contamination, not just from the skin. Sometimes if they don't maintain good hygienic conditions, the testosterone may fall on the, say, the doorknobs and other areas of the house, and potential contamination can occur. Let's go to the first case. This is called the hairless face. A young 33-year-old gentleman. I saw him many years back. He has reduced facial hair. He has backache. The testis is 3 ml. It's small, soft, and atrophic. There is a phallus palpable, but there is no real erectile tissue palpable. So if you look at this gentleman, he has really no sexual hair on his body, but on his face there is absolutely no hair. He is not young, he is 33 years. He has backache, which could suggest, though osteoporosis doesn't cause backache, it could suggest osteoporosis. The testis is small, which suggests hypogonadism, but if it's Klinefelter's, it's usually hard. But this is a soft atrophic testis. This is good old clinical examination. Today people use ultrasound, but good old clinical examination can also detect this. And of course, he has no erectile tissue palpable. So this is probably a case of hypogonadotrophic hypogonadism. And this is the oxidometer which Dr. Krishna Seshadri was alluding to. The adult testis has to be at least 20 ml, and to say the testis has undergone puberty, it's 4 ml. So you compare the various beads of the oxidometer with the testis, and you can diagnose hypogonadism. Testicular atrophy in an adult, if it's less than 12 ml, you can say that there is testicular atrophy, and there are lots of inter-individual variations between people and between races, and this is something, but in general you can use an oxidometer for a good assessment of the genitalia. So because of backache, when his T-score was done, you can see the T-score was low, and that suggested osteopenia, and his LH was undetectable, the FSH was undetectable, the testosterone was also low. So therefore, we know that it is the hypothalamus which produces GnRH, which stimulates the pituitary, which produces LH and FSH. LH stimulates the Leydig cells of the testis to produce testosterone. FSH stimulates the Sertoli cells of the testis to produce spermatogenesis. So in this gentleman, you have a low LH, low FSH, low testosterone. So the problem could lie in the pituitary, but it could also lie in the hypothalamus. So it could lie in the pituitary or in the hypothalamus. And you can see his MRI shows a large sella suprasella mass, which eventually was diagnosed to be a craniopharyngioma. So it's a cellar mass involving the pituitary and a suprasellar mass involving the hypothalamus. Sometimes a simple X-ray of the skull, if patient is not affordable for an MRI, simple X-ray of the skull may detect stippled calcification in the suprasellar region, and you can pick up the diagnosis. So he underwent surgery, he underwent radiotherapy, he developed hormone deficiency, and he was eventually given testosterone enanthate, 100 milligram IM for the first month and then 250 milligrams. Is this the way to treat hypogonadotrophic hypogonadism? Probably not, because you need to give gonadotropins to the patient, you need to inject HCG to the patient to stimulate the Leydig cells. You need to inject FSH to the patient. But it also depends on the patient's affordability, the patient choice. And in a country like India, there is a study published in the Indian Journal of Endocrinology and Metabolism that many patients do not want fertility first. They want virilization first. They want androgenization first. And they are not able to afford complicated gonadotropin therapy and may settle for testosterone replacement. And this gentleman was given 100 mg per day for the first month and then 250 mg per day. The reason we give 100 is sometimes if we give 250 mg, patient may get priapism, painful erection. So therefore, you start with 100 and slowly build up the dose. So we've concluded case 1. Now I go on to case 2. Now this is a 71-year-old gentleman. He is noted mild decline in his libido and muscle mass, and the routine investigations are really unremarkable except for the testosterone, which is low, LH and FSH, which are on the low normal side, and the prolactin, which is quite all right. This is what is called androgen therapy in the aging male, and people can call it, some people like to call it andropause, some people like to call it androgen deficiency in the aging male or ADAM. Some people like to call it late onset hypogonadism. Some people like to call it partial androgen deficiency in the aging male. So this is not a very evidence-based slide, because this just tries to show you, these are pictures of Wahida Rahman, an actress, but I'm not trying to point out anything here. I'm just trying to show that in a lady, menopause is a very gradual process. These are pictures of her, and this is a very gradual process. I don't want you to draw any conclusions from this picture, but just to tell you that menopause is a gradual process in women, but it has an abrupt onset at some point of time, whereas in men, it is an even more gradual process. Again, this is not an evidence-based slide. This is just to wake you up, and this doesn't say that Amitabh Bachchan had a gradual andropause or anything like that. It's just to say that, just to make the point that while menopause is a gradual onset in women with a sudden onset of menopause, if you like, in men it is even more a gradual process. And therefore, at each point, you're faced with a dilemma whether to treat or not to treat. And that's very difficult, because in women, of course, hormone replacement therapy has been shown, long-term HRT has been shown to be virtually not good, because it has more risks than benefits. In men, the decision can be even more difficult. Of course, you can give symptomatic menopause, you can give short-term hormonal therapy in women. In men, the decision is even more difficult, because the symptoms are subtle, they're very slow, and whether to treat or not to treat. And you cannot tell anybody that, okay, you are old and you don't deserve treatment. I think everybody who wishes treatment should be given a chance or should be considered for treatment. So as Dr. Krishna Seshadri showed, the testosterone, actually the free testosterone, when you compare the young with the old, free testosterone is a little low in older people. The albumin bound fraction is fairly okay, but the sex hormone binding globulin increases, and that's why the free testosterone may be a little low, and these several studies have shown that. And with age, you can see the sex hormone binding globulin increases, the free testosterone starts coming down, and the total testosterone also shows the decline. So how do you diagnose androgen deficiency in an aging person? So you measure the total testosterone. You can do a free testosterone also, but you don't know how good the lab is. You take a mid-morning sample, 8 to 11 a.m. You don't have to do a fasting test. You can do a fasting test if you wish, but it's not necessary. If a testosterone value is less than 345, it's not diagnostic, it's just suggestive. You can just evaluate further, and you need to take 2 samples 2 weeks apart, because as you know, nothing is set in stone, and every human being may orbit in his or her ranges of testosterone, and so you need to have some idea that is there a regression to mean happening or something like that. You can calculate the testosterone and the bioavailable testosterone using these softwares which are now available, but this is just a rough guideline. If you find that, if you suspect partial androgen deficiency in an aging male, you measure the testosterone. Of course, you need to do prolactin and do FSH-LH. Like Dr. Sheshadri showed you, you need to consider the possibility of a pituitary adenoma. But having done all that, and you think this is a classic androgen deficiency in an aging male, if it is less than 250, you will probably end up treating the patient. If it's 250 to 345, I would like to hold on therapy unless very symptomatic. If it's more than 345, I would say it's a normal person. So these are some of the guidelines. Now, the US guidelines say that if you can measure the free testosterone and if it is below 6.5, you can still consider it significant, which means if your total testosterone is 250 to 345, you measure the free testosterone, and if it is below 6.5, you can still consider it significant. You also, if you do find, like Dr. Sheshadri showed you a classic case, if you find that the FSH-LH is normal or low, you need to do an MRI of the pituitary to rule out a pituitary tumor or a hypothalamic tumor. And you need to do, prolactin can also pick it up, and you need to do a serum ferritin because sometimes you can get hemochromatosis, especially in younger people. And if the LH-FSH is high, you've made the diagnosis of primary testicular failure and you can start therapy. Now, there are various preparations of testosterone available. You have implants, you have short-acting injections, you have tablets, scrotal patches, you have body patches. This is an old slide. You have testosterone gel, which is available in India. Like Dr. Sheshadri showed you, it has a risk of contamination, and I don't use it I don't advise it in my practice to patients. I would rather give the long-acting testosterone injections. The testosterone injections have to be given once a month. You can give it up to once in 2 weeks. Some people like to do the peak testosterone level. So if they're giving it monthly, they check it after 15 days. I like to do the trough levels because, so for example, if my patient is on testosterone every month, I tell him to do the testosterone level before the last dose, just to make sure the minimum he's getting is okay. But many guidelines say that you should do the 15-day dosage because you can get the peak levels. But in India, I think a trough testosterone is good because you can make sure that your patient gets the bare minimum testosterone that he gets throughout. If once a month isn't working, you can give it once in 15 days. Now, word of caution, again, this is not to blame any product, but you are all aware that there are several long-acting injections. There is testosterone and there is sustanon. So, just to say, long time back when I was teaching endocrinology, I saw a patient teaching endocrinology in a university. Now I teach endocrinology in CMEs. So, thank you. And then I saw a patient who was treated by an outside doctor. So the doctor prescribed sustanon for classic hypogonadism. Patient had gynecomastia, and the patient came with worsening of gynecomastia after testosterone. And I wondered, is it because of adipose tissue and testosterone getting converted to estrogen? Finally, I asked for the injection, and I found that instead of taking sustanon, the patient was taking susten, which is progesterone. So you have to be very careful, the opposite thing can happen. So the pharmacist has to really give testosterone, means sustanon. If you are giving sustanon, give sustanon. Otherwise, you can give testoviron depot. That cannot be mistaken for any other thing. Or you can simply write testosterone enanthate long-acting depot. But if your patient gets sustained by mistake, I've seen it. This very problem that you've treated is going to become worse. So be aware of these problems that can happen. So these are some treatment options. Testosterone andecanoate is a tablet, a pill, which we don't use because it directly goes to the liver, and first phase liver clearance can cause hepatotoxicity. You can give testosterone enanthate injection, 250 mg a month. You can give testosterone propionate injection. You can give long-acting once in 3-month injection. Again, I don't use these in my practice. I like to stick to plain testosterone enanthate injection, 250 mg once a month. And I think if you give it one injection, it peaks in about 2 to 4 days and it lasts for about 2 to 4 weeks. This may vary from person to person, and you can give it once a month therefore. And as I said, in my practice, I prefer not to check the peak levels. I prefer to check the trough levels because I find in India that's a better way of ensuring that throughout the period the patient gets a minimum dose. There are benefits of testosterone which are very clear in partial androgen deficiency of the aging male, not in hypogonadism. Hypogonadism is very clear. Definitely it increases testosterone levels, it improves the libido, testicular sexual function, may possibly benefit bone health, and it may improve the muscle mass, but the benefits on fractures aren't very clear. Doubtful whether it will have any benefit on memory, mood, or cardiovascular disease risk. There are lots of risks of testosterone. There is fluid retention, there is liver toxicity. Testosterone, as I showed you, can worsen gynecomastia because testosterone can be converted by the adipose tissue into estrogen. That can worsen gynecomastia. Sleep apnea may be an effect. Polycythemia can occur. The counts have to be monitored. You need to check the HDL because androgens can actually lower the HDL levels. And if your patient has CA breast or prostate, you need to be careful. So liver toxicity you need to monitor once in 6 months, and polycythemia and lipid profiles you need to do. In a meta-analysis, a long old study of 22 studies, in 16 it was normal, in 583 men, the average PSA used to increase at the rate of 0.52 per nanogram per ml per A. So you can expect a slow increase in PSA when you give testosterone. So therefore, you need to do PSA when you put your patient, not that PSA is a great test. You can do ultrasound as well to detect a prostate enlargement, but you need to monitor for prostate enlargement. At least every 6 months or every year at least, you need to do that. And if you find PSA abnormal, you can do an ultrasound, but if you are really worried, patient also needs to be monitored better, you find the PSA increasing, do an ultrasound every 6 months if you give testosterone to an aging person for an andropause-like situation. Make sure that PSA is below 4 nanogram ml per therapy, because if it's above 4, then the risk of it going up becomes very high. I think not everybody's PSA changes with testosterone. This is a mean value, so you can be quite confident that things will be reasonably okay, but you need to monitor. So there is a role of in patients who don't respond, if the sexual function doesn't respond with testosterone, you can always add sildenafil to testosterone, because there's an RCT which showed that hypogonadal men who fail testosterone can be given, of course, sildenafil, but who fail sildenafil, the study showed they could be rescued by additional testosterone because increased arterial dilatation in the phallus was observed. And in type 2 diabetes, 70% of patients with androgen deficiency who do not respond to sildenafil may respond to testosterone. But as I said, I do not prescribe oral testosterone because of the first phase hepatotoxicity. I prefer to give injectable testosterone. So I had introduced the topic. I've showed you the case 1 of a hypogonadotrophic hypogonadism with osteoporosis and a craniopharyngioma detected at 33 years. I showed you another case of an elderly aging male and discussed partial androgen deficiency. I'd like to summarize by saying that partial androgen deficiency is frequent, but it's not omnipresent. Not everybody has it. Suspect it if the testosterone level is below 345 nanogram per deciliter, but treat it when it's really below 250. Symptoms and biochemical proof you need. Long-acting injections are practical in India. Try not to use oral tablets, and if you are advising a gel to your patients, be very careful because it has a risk of contamination and patient has to really use it properly in addition to the cost. Surveillance focuses on the prostate size and hematocrit, and really there's no evidence that testosterone therapy could benefit CV risk. So I'd like to end with this slide. Some people like to go away and age with grace. This is Yeats who said that, I heard the old men say, all that's beautiful drifts away like the waters. Some people like to fade gently into the night, accept aging with grace, accept them becoming old, get ready for the next birth if you have such a belief. So they are happy with that. They don't need testosterone. There are some people on the other, like Dylan Thomas said, do not go gentle into that good night. Old age should burn and rave and rage against the dying of the light. They want to work till their last minute. They want to be active till their last minute. They want to go with a bang. They don't want to look old. They want to dye their hair. They want to look young. And for them, you have to look at the pattern of the person, the wishes, before you actually give testosterone. Ladies and gentlemen, thank you for listening to me. It's a pleasure talking to you.